This is going to be an interesting talk. This is titled Clinical Considerations for a Special Needs Child with a Complicated Mosaic Diagnostics Organic Acids Test. So before I get started, just a little bit of background on myself. I've been an integrative functional medicine physician since the late 90s. I've written a number of books. I love education. I'm a practicing clinician. I'm the founder and clinical education director for this academy, Integrative Medicine Academy. I'm also the founder and education director for a website called Autism Recovery System. I'm currently the chief medical officer for Mosaic Diagnostics. And I'm also the host of Functional Medicine Doc Talk podcast. We're just about to complete our second season. You can go to functionalmedicinedoctalk.com and check out who we've interviewed, some great interviews there. And then in my own practice, I've worked with children with autism and other special needs disorders for decades now, people with environmental induced health problems, chronic complex health issues. So I've had a lot of experience in the functional and integrative medicine space. And I've also taught a lot about the organic acid test going back to the Great Plains days and now currently for Mosaic Diagnostics in what I feel is one of their most important tests, and really a test that every practitioner who is in the integrative functional space should learn how to interpret, how to incorporate in practice, and understand its utility. Now, you might be aware, maybe not, that there has just been a new report enhancement that has come out with the organic acid test. It's been decades since there was any kind of report enhancement for this test. There's actually some great additions with this report enhancement. Essentially what they've done is create 6 clinical categories from microbial overgrowth, mitochondrial health, neurotransmitter metabolites, toxic exposure, nutrient needs, and methylation. And really the idea behind this was trying to bring forward markers that not only have clinical significance individually, but also how those markers can line up or connect to other markers on the organic acid test in what is called pattern recognition. So one of the key aspects of learning how to interpret the OAT is to understand patterns. Yes, individual markers are important, some more than others, but it's the patterns of these markers that's very important to understand. Now, another key aspect is that nothing at this point has changed on the OAT with regards to the markers, the reference ranges, the technology that was used. The only thing that's really changed is that summary page bringing forth those clinical patterns and then the way the test looks. So the previous test, which you see on the right, you have everything on page 1, page 2, it's all the same markers. It just has a different look now. So when you actually compare a previous test to a new test, if you just get into the meat of the test, there is no difference in the way the test is laid out. And you can if you're more comfortable with the previous version, you can easily interpret the new format. What they've also done at Mosaic was to improve the interpretation sections. So each individual marker now has its own specific interpretation paragraph. And they've also incorporated these clinical category icons. So we got microbial overgrowth, mitochondrial health, nutrient needs, etc. So for example, if we took 5-hydroxymethyl-2-fluorouric, we know that this comes from Aspergillus exposure. So that would be linked to a microbial overgrowth pattern. And so that icon is listed in that particular section. We know that Aspergillus can produce various mycotoxins. So it can have a toxic influence. And so essentially the toxic exposure icon is also placed within that paragraph. So it basically just kind of helps to orient you a little bit more to the clinical categories and then the clinical significance of what some of these markers are. And that occurs for each interpretation and each marker on the test. There is a new 223-page provider support guide. This thing is loaded with information. You can actually find this off Mosaic Diagnostics homepage, if you go into the section for the organic acid test, you can download it as a PDF on your desktop. I have my own copy. And what's super cool about it is when you go into the table of contents and you can, there's a marker you want to learn more about. Let's say, for example, we commonly see this marker for creosol on the Mosaic OAT. It's found on page 34. And when you actually click on it in the PDF, it will take you specifically to that page. And it'll give you much more detailed information than even the interpretation section within the test provides. So you not only want to go through the interpretation section of the test itself, but you also want to also look into the clinical support guide for additional information. And what we know about for creosol, for example, is that it comes from Clostridia bacteria, specifically Clostridia difficile, and it is a major inhibitor of dopamine beta hydroxylase. So it can disrupt catecholamine metabolism, specifically of dopamine. The other thing within the new test is these additional diagrams. So we've got the citric acid cycle, not only the citric acid cycle, but looking at glycolysis and how it connects to the citric acid cycle. We've got one for neurotransmitter pathways, and there's even a one for methylation and detoxification pathways. And these are found on various pages within each organic acid test. Okay, so the more tests you do, the more you're going to see, obviously, of this new format. I highly recommend getting that provider support guide as well. So let's get into the meat of this topic. I want to go through a complicated organic acid test, and this is of a special needs child from my practice. And the main point of this exercise is not to get into all of the nuances of treatment. I want to just really highlight the test, and I want you to come away with some better understanding about how to think about things clinically when you're looking at an organic acid test. Now, because the new format is new, there's not a lot of them out there yet in practice, so I'm actually pulling this from my practice. And so essentially what we're going to be doing is looking at an old format, old as of like last week, of the organic acid test. So, but we understand that the information is the same. So this was a young special needs child. Now this child's main issues was they're nonverbal, which is pretty typical. The child does make some vocal sounds, but no noticeable language. Very little receptive language ability too. So executive function is a bit difficult to assess, but there's not a hearing problem. So auditory examination is normal. No social interest. The child does have some siblings, but they prefer to be alone. Really not interested in children, you know, in the outside world, whether they go to the school or at a playground. They're really just kind of prefer to be alone. No significant behavioral problems such as self-injury and aggression, which is fortunate. That's always a question I ask parents. Is the child aggressive or self-injurious? And that's not the case here. This child does a lot of side glancing and hyper focuses on spinning objects. This is a very common thing from a sensory imbalance standpoint. It's difficult to know exactly what causes it. Certain inflammatory issues in the brain probably lead to it. I have seen situations where it was exacerbated by candida, but again, it could be multiple reasons. Low muscle tone, low energy, poor balance, lack of coordination. This child actually doesn't like to jump or run. Whenever I hear this, I start to think that there may be some underlying mitochondrial problem, particularly the low energy in a young child. That's not real typical. So probably a mitochondrial issue of some sort. And then constipation is a major concern. And this child can go for weeks without a bowel movement. They're really dependent on laxatives and enemas. So that is a major struggle. So if we look at page 1 of the organic acid test under the yeast and fungal markers, we can see multiple things elevated. The most common marker you see is arabinose. We can see the level here is extremely or very high at 157. One thing to keep in mind about arabinose is that marker gets generated when we have mucosal reactivity to invading candida. That particular marker is not diagnosing what's called candidemia, which would be systemic or invasive candida, but we do know it's mucosally reactive. Tricarboxylic is linked to Fusarium mold exposure, and then you notice that markers 2, 4, 5, and 6 indicate Aspergillus mold exposure. So what are some clinical considerations? Well, there's multiple fungal markers elevated, both mold and candida. Now, we know that Fusarium mold can come from foods such as corn and corn products, but it can also be from environmental sources. So you shouldn't assume that it's just food-based. Aspergillus on the oat indicates digestive system growth, most likely from environmental exposure. So we can basically inhale or digest Aspergillus spores, and they can colonize within the digestive system or grow within the digestive system. And those oat markers are a reflection of that occurrence. The question to ask is there a mold contamination in this child's environment? And I'll show you the next slide. And then what are some other tests that should be performed? Well, in this particular case, minimally, an additional test should be a mycotox profile to look for mycotoxins. We don't want to use the oat as a sole determining factor of the existence of mycotoxins, either ruling it in or ruling it out, because you'll have situations in practice where the organic acid test is normal for the mold markers, but they still have elevated mycotoxins. So the mycotox profile should be done. Now, in this particular case, I'm not showing you the full test, but this family did do a home mold test from Envirobiomics, and sure enough, their home was rated very moldy, to the point actually that the company in their analysis recommends strongly that the individual or the family be out of their home while it's, until it can be remediated. So that, that's another discussion, but we do know that there is some mold in the environment. Now, within Integrative Medicine Academy, if you actually go to the resource section, so if you go to the web page under resources, we do have a webinar section, and we also have educational videos. And these educational videos are short videos, 5, 6, 7 minutes at length. And there's a video there that you can watch called Comparing the Organic Acid Test and the Mycotox Profile with regards to mold and mycotoxin exposure. So I'll go a little bit more in depth in looking at the oat test, particularly those markers on page 1 with the yeast and fungal markers, and what you'll see sometimes on mycotoxin testing. As we come down on the first page of the oat, we see some elevated bacterial markers. So we know that there's some bacterial dysbiosis. Markers 11, 12, and 13 are commonly elevated when there's a lot of bacterial imbalances in the digestive system. These markers aren't specific to any given pathogen. They just indicate dysbiosis, but keep in mind that markers 12 and 13 could also be coming from paraben exposure. So parabens are things that we often get exposed to in various products. So for example, a deodorant and antiperspirants have parabens in them. So an additional consideration, if you see those markers high, is maybe do an environmental chemical profile. The Tox Detect profile from Mosaic Diagnostics is excellent. This is just a sample. This didn't come from the child we're talking about, but I do see elevated parabens fairly frequently in people, more so in adults who are using personal care products and cosmetics. So I don't expect a young special needs child to be putting on antiperspirant. So, but again, just an additional consideration that those markers on the oat first page in the bacterial section could be paraben exposure. Now, this is where, for me, things get, fairly important with regards to try to understand what's happening in a given individual. So this is the Clostridia bacterial section of the organic acid test. And you can see in this case, the first 3 are elevated. The most common one to see elevated is HPHPA. That shows up probably 80% of the time when one of these Clostridia markers is present. So it's fairly common. For creosol, second on the list, about 15% of the time. And then we also have the 4-hydroxyphenylacetic. So it's not common to see all three. So all three really indicates we've got a major problem in the gut with regards to either immune function, microbiome disruption, and these things are problematic, particularly in a special needs child, because they can really create mischief within the brain and nervous system. So some clinical considerations is to try to understand what is the significance. Should we do some further testing? I don't always go to a stool test, but in this particular case, it could be worthwhile. We know that this child has severe problems with constipation, so it may be a good idea to take a look at some digestive markers, markers of inflammation, other microbiome imbalances. These Clostridium markers, by the way, themselves can lead to constipation too. So certainly a CDSA would be a strong consideration. I could also comment that doing a glyphosate testing like the Tox Detect, we know that a lot of people who have chronic exposure to glyphosate will often have Clostridia problems. And then the other question is are these bacterial toxins causing significant behavioral or neurochemical problems? Well, the behavioral problems don't appear to be happening, at least in this particular child yet. A common scenario with these Clostridium markers is they can drive aggression and self-injurious behavior. This child is not aggressive or self-injurious. That doesn't mean we'd leave the markers alone. It's not that they're benign. It's just fortunately we're not getting the aggressive and self-injurious behavior in this particular case. The neurochemistry problems can be analyzed to some degree further down on the organic acid test. Now, on the newer version of the Mosaic OAT is this neurotransmitter pathway. And what we know is that these Clostridium markers, particularly for creosol and HPHBA, can interfere with dopamine metabolism by interfering with what's called dopamine beta hydroxylase. So that image is where I circled here on this neurotransmitter pathway. I actually like this chart too. This is on the old format of the OAT. So right here is our dopamine beta hydroxylase, which converts dopamine to norepinephrine. That gets interfered with by the presence of those Clostridium markers. And when that happens, if it happens long enough, we can start to see an increase of dopamine that is reflected on the organic acid test as an elevation of DOPAC and many times an elevation of homovanillic acid. So here's what's happening. Clostridia difficile will grab tyrosine and convert it to 4-creosol, and then that causes an inhibition of dopamine beta hydroxylase. HPHBA, because of its similar chemical structure, appears to also inhibit that enzyme. The bottom line is over time, we can start to get excess levels of dopamine. Dopamine metabolites are toxic or neurotoxic within the brain and nervous system. And then we are going to also get a depletion of norepinephrine and epinephrine over time as well. So if you've seen some of my webinars of the past, or if you've taken some of my courses, you've probably seen this image before. I talk a lot about it in our Essential OAT and Advanced OAT Mastery course. Oxalates. So we can see in this particular case, oxalic acid is very high in this particular child. And that can occur because of diet. So they certainly could be eating high oxalate foods. So you need to do some inquiry into what their diet is like. It can also occur because of the presence of fungus. So by the way, glyceric you see also elevated can come from Aspergillus exposure. So what are some clinical considerations? Well, could it be diet related? So you just need to inquire about the diet. In this particular case, the child was not on what I consider to be a high oxalate diet. We know that Candida can produce oxalate. We know that Aspergillus can produce oxalate. The big question too is the child having significant behavioral or physical problems from the presence of high oxalate? Well, when it comes to oxalate in a child with autism, if they're really affected by it from a physical standpoint, you often see a lot of negative behavior, irritable, agitated, sometimes aggressive, sometimes self-injurious. That doesn't always happen. Again, it doesn't mean it's benign, because the oxalate can form crystals, it can sequester minerals, it can lead to mineral imbalances. So again, it's not that we're going to leave it alone, but we're trying to tie back the marker to some sort of clinical presentation. So aspergillus can actually directly produce oxalate. So the image on the left is aspergillus niger, so producing oxalate. On the right is candida. Candida, as part of its Krebs cycle, has an enzyme called isocitrate lyase. It takes isocitrate from the Krebs cycle, converts it to glyoxylate, which gets converted into oxalate. So in most of these situations, by the way, when you suspect that the oxalate is coming from fungus, well, you got to treat the fungus, and that often is a fix, or at least reduces the oxalate load to a significant degree. We're not getting into treatment aspects here, but again, we're just through the exercise here. We're just trying to look at some patterns and questions to ask. This particular child had a lot going on in the glycolytic as well as the Krebs cycle pathways. So notice that pyruvic is high, lactic acid is high normal, and then we've got elevated succinic, fumaric, malic, as well as an elevation of citric. So what are some considerations? Well, the high normal lactic may be significant. The high pyruvic is significant, and likely both are linked, or at least the pyruvic is strongly linked to a problem in what's called pyruvate dehydrogenase. Now, there are other multiple markers that we're seeing elevated in this Krebs cycle. So for example, if we go back, you'll notice that succinic is high. So high succinic can occur from genetic influences, probably not likely in this case. Nutrient deficiencies, that certainly could be likely. Environmental exposures from chemicals, glyphosate, metals, and even mycotoxins. Well, we already know there's mold. We don't know about chemicals and metals. We'd have to test for it, but we know there's mold, and there's likely mycotoxins. The high citric you see elevated here can occur from the lack of antioxidants like glutathione. So it's possible, by the way, we could even see an elevation of succinic because of glutathione deficiencies. So that's a pattern recognition scenario that's common on the organic acid test, is trying to understand what are some of the markers that came before that could be influencing this particular section of the test. So we know we've got some mitochondrial imbalances. We know this child has poor energy, poor coordination. So something is affecting them from a metabolic energy standpoint. If I was going to consider an additional test, the mitoswab from Religen would be a good choice. That looks at functional aspects of the electron transport chain. That test often complements the organic acid test. And I get very deep into mitoswab testing in our mitochondrial mastery course. So here's the pyruvate dehydrogenase complex. So notice that pyruvic acid. So remember, glucose gets converted into pyruvic acid. Pyruvic acid is then converted into acetyl coenzyme A through the actions of pyruvate dehydrogenase. These acronyms, coenzyme A, this is linked to B5. NAD is linked to B3. TPP is thiamine. NADH is also B3. FAD is linked to vitamin B2 or riboflavin. So what that tells us is that this enzyme is dependent on a lot of these B vitamins to function properly. And if we've got deficiencies in these B vitamins, or just a few, we can start to get an elevation of pyruvic acid, and that can cause downstream problems in the Krebs cycle. I'm going to come back and show you how the pyruvate dehydrogenase connects to other dehydrogenase complexes within the mitochondria. Well, the neurotransmitter section is next in line. What's interesting in this particular case is that in the presence of Clostridia bacteria, we know that HP, HbA, and at least 4-creosol are inhibitors of the dopamine beta hydroxylase. So theoretically, we should see an elevation of homovanillic acid and even an elevation of DOPAC. It doesn't appear to be occurring, at least to a significant degree in this example. That doesn't mean it couldn't happen down the road if we just left things alone. Every test you do is a snapshot in time. When we do see elevations of the dopamine, for example, it often is linked to aberrant, behavior, aggression, self-injurious, hyperactivity, irritable. So it's not happening in this particular case. What you will notice too is an elevation of this marker called kynurentic. Now, what's kind of interesting in this particular scenario is kynurentic is not a common marker to be high. It's thought to be linked to a need for additional B6. It may be elevating as a compensatory reaction for the production of what's called nicotinamide adenine dinucleotide. And I don't have a graph on that, but essentially what happens, you'll notice that quinolinic acid is normal, but it's sort of mildly high, maybe elevating. And if we were to track this over time, we might see it start to elevate. In the presence of various stressors, mental emotional stress, physical stress, infectious stress, etc., the body starts requiring more NAD to help in energy metabolism. And we can start to see elevations of quinolinic acid occur because of that. Kynurentic acid is a bit of a biochemical break against too much quinolinic acid production. So some of that just comes with doing the test and looking at the test over time. But it was just kind of an interesting pattern in this particular test and why this particular test is fairly complicated to evaluate. So it doesn't have the classic presentation. We've got 3 Clostridia markers high, but essentially the neurotransmitter metabolites, specifically those linked to dopamine, that would be the phenylalanine tyrosine metabolites, look relatively normal. What isn't normal is our ketone and fatty acid oxidation section. So notice that 43 and 44 are elevated, significantly more so than the other markers that are high. And when these become elevated, we've got some problem in metabolizing fat at the cellular level. Typically, when we see 45, 46, 47, 48, 49 elevated, there's a problem in getting fats into the cell and into the mitochondria to be used as fuel. Now, a relatively easy thing to do is to administer L-carnitine, for example, because that helps to transport fat into the mitochondria. But that's not a full explanation, or that doesn't always work just by itself. I like to think that sometimes it's better to try to understand what else may be going on. Methylmalonic and methylsuccinic are commonly elevated when there's a lot of oxidative stress in the mitochondria. And one of the things that was elevated prior, or was mildly high in this case, was lactic acid. So when we've got underlying mitochondrial problems, including oxidative stress, one of the things that can commonly elevate because of that is lactic acid. So I think that there's something deeper happening here at the mitochondria. So L-carnitine is certainly supportive, but I think there's something else going on. And certainly that might just be exposures that they have, like mycotoxins. Notice again that 43 and 44 are much more elevated than the other markers on this section of the test. So what are some clinical considerations? Well, we can see elevations of 3-hydroxybutyric and acetoacetic in somebody doing a ketogenic diet. So that would be a fairly simple thing to ask. Is your child doing a ketogenic diet? In this case, they were not. Could there be developing insulin resistance, metabolic problems? Is the child diabetic? In this case, they were not. You can apply that information to an adult when you do an OAT test, and that might be the case. more likely than not, we're dealing with some kind of imbalance within the electron transport chain or within the mitochondria with regards to how fat is processed. Some of this could be nutrient deficiency based. And another pattern that can be associated with elevations of 3-hydroxybutyric and acetoacetic is a need for additional niacin or vitamin B3. So what are some additional tests that could be done? Well, we could do a metabolic profile, looking at blood chemistry, glucose, fasting, insulin, hemoglobin A1C, if there was a concern, for example, of insulin resistance or developing diabetes. I think minimally walking away from this section, we could implement some L-carnitine supplementation to at least assist the cell and the mitochondria from transporting fats. But again, there's likely deeper things happening here. Under the nutritional marker section, we can see a few things out of balance. The main one I want to focus on is marker 55, the 3-hydroxy-3-methylglutaric. Now, remember on the organic acid test from Mosaic, a marker that has an asterisk next to it. So that would be 50, 53, 55, and 57. When those markers are high, it indicates a deficiency of its respective nutrient. So in this particular case, 3-hydroxy-3-methylglutaric elevations indicate a CoQ10 deficiency. Would that make sense based on what we've already seen within the Krebs cycle section of the test? I think it would. Okay, and CoQ10 lives within the first 3 protein complexes of the electron transport chain. So there's clearly a deficiency here. And that's a problem because if we have a CoQ10 deficiency, we can't transport electrons effectively down the electron transport chain. So CoQ10 is a no-brainer, in my opinion, with regards to a supplement to incorporate. But the bigger question is one, why is it happening? And two, could this also be a contributing factor to other sections on the OAT? Well, most certainly. A CoQ10 deficiency could be another reason why the Krebs cycle and other mitochondrial markers were elevated on the additional page that we looked at previously. And so what's important to understand is that the fungal exposure, the Clostridia exposure, the oxalates, the CoQ10 deficiency, all of those things could be negatively affecting things at the mitochondrial level. Under the indicators of detox, we've got a couple of markers high, well, all of them are high actually. The orotic is linked to ammonia excess. 2-hydroxyhyperic, most commonly at that level, is probably coming from intestinal bacteria. I don't get that excited about a level that high. I think the orotic ammonia excess, again, probably from intestinal bacteria. The two I want to focus on are the pyroglutamic and 2-hydroxybutyric, and notice they both have an asterisk. Again, so when those markers are high, pyroglutamic is high, it indicates a deficiency of glutathione, and when 2-hydroxybutyric is high, it indicates an increased demand for glutathione production. So the question to ask is, why is pyroglutamic elevated? Why is glutathione deficient? Is the child not making enough? Is there some genetic problem? Maybe it's all the other stuff we've already gone over. Maybe it's the fungal exposure. Maybe there's mycotoxins we need to test for. We probably should test some chemicals too. There's just a toxic load that's happening that's draining the glutathione reserves or the ability to maintain glutathione levels. That would also be true with the elevations of 2-hydroxybutyric. So the methylation transsulfuration pathway. Let me draw a line under here. So here's our methylation cycle. Here's our folate cycle. Coming down this direction is our transsulfuration pathway. So homocysteine gets converted to methionine through the actions of methionine synthase enzyme. Here's our MTHFR, which is dependent on riboflavin for its actions. And then we have our MTH or 5-methylfolate, which is what methylates cobalamin to help convert homocysteine to methionine. coming in this direction. So it's a balancing act, right? So we can look at homocysteine at 6 o'clock, methionine at 12 o'clock on our clock face, but it's a balancing act between homocysteine being pulled into the transsulfuration pathway or playing a role in the methylation folate cycle. If we have increased demand of toxicity in our body's going to want more glutathione. And as it pulls things in this direction, okay, we can actually get an increase in that chemical called 2-hydroxybutyric. So that's why I say 2-hydroxybutyric elevations most commonly are linked to an increased demand to try to maintain glutathione. And it's important to say, well, what can we do? Well, you could, let me get rid of these things. It doesn't want me. Well, let me get rid of these things. So we could give glutathione, but I always like to ask the question, well, why is it happening? And what are some things we need to consider next as far as why the body is reacting this way? And again, so we have further testing to look at and further things to consider. And the first test, if this patient and in this particular family, they could only afford to do one thing, one additional test, it would be the mycotox profile. We've already got documentation of mold exposure. We've got overgrowth coming from within the digestive system. I want to see what the mycotoxins are. What makes this particular test too a little bit more complicated than most are a few of the other markers that show up. So this is the last section of the organic acid test looking at amino acid metabolites. Now, a lot of people get fooled in thinking that low values means that there's an amino acid deficiency, and that's not the case at all. Low values are normal. These are markers that are linked to inborn errors of metabolism. They're truly significant from an inborn error standpoint when they're very, very high, and those are not common. Markers 62 through 66. Okay, when these are elevated, and you'll notice that the 3-methyl-2-oxovaleric is high, a very common scenario is a need for additional thiamine, vitamin B1. So where is this marker and what's it linked to from a true disease standpoint? It is considered a neurotoxin. So elevated levels can lead to damage within the nervous system. Chronically high levels of 3-methyl-2-oxovaleric are associated with an inborn error metabolism disease called maple syrup urine disease. And this is a metabolic disorder that's caused by a dramatic deficiency of what's called branched chain alpha ketoacid dehydrogenase complex. And I know that's a mouthful, but I'm going to show you how this ties together. And that can lead to a buildup of leucine, isoleucine, and valine, and some of their what are called keto acid byproducts. So what are the symptoms of maple syrup urine disease? Okay, well, it can be uncharacteristic and inappropriate and erratic behavior, rapid neurological deterioration, hallucinations, weight loss, nausea, vomiting, seizures, coma, and then unfortunately death in individuals who are greatly compromised. This child does not have maple syrup urine disease. They don't have really any of these manifestations. So a slightly elevated marker like we see here, okay, although it might say it in the interpretation section, it could be coming from maple syrup urine disease, you have to put 2 and 2 together and realize that's an extremely rare genetic disease, not likely to be seen in most clinical practices unless you're working in a clinic of the inborn, errors of metabolism. So what's the most likely scenario? Most likely scenario is it's coming because of a thiamine deficiency. So here's our pyruvate dehydrogenase complex again. So pyruvate gets converted to acetyl coenzyme A through the actions of these various B vitamins. What's interesting is that pyruvate dehydrogenase, which is dependent on those B vitamins, has relationships to other dehydrogenase complex enzymes within the mitochondria. So there's another one downstream called alpha ketoglutarate dehydrogenase. And that complex requires the same nutrients. It requires B1, B2, B3, B5. And so deficiencies of any of these can lead to elevations within the Krebs cycle, from precursor compounds that get inhibited from being converted downstream because of deficiencies in these enzymes. And then there's this guy, the branched chain alpha ketoacid dehydrogenase complex. So this particular enzyme is linked to the metabolism of leucine, isoleucine, and valine. Now just look at the image for a second and don't get lost in the individual names of the chemicals downstream. Notice that the acronym BCKDH, that is the enzyme complex. It's very similar to the pyruvate dehydrogenase, very similar to the alpha ketoglutarate dehydrogenase. It requires the same nutrients. But look at where it flows. Leucine flows and becomes acetyl coenzyme A. So this is one way that we can get leucine amino acid to generate energy within the Krebs cycle. Isoleucine can become either propionyl coenzyme A or acetyl coenzyme A. Valine becomes propionyl coenzyme A. Downstream from that, propionyl coenzyme A becomes succinyl coenzyme A. Well, that's just another doorway to the Krebs cycle. So acetyl coenzyme A enters at the first step, basically merges with oxaloacetic acid to become citric acid. Succinyl coenzyme A enters a little bit lower down the chain reaction during the first half of the Krebs cycle. But either way, these are just different doorways to the Krebs cycle. But if we have a block in that branched chain ketoacid dehydrogenase, and we have a block in either the alpha ketoglutarate or the pyruvate dehydrogenase, we can get inflated markers that occur linked to these deficiencies. And so this child had elevated pyruvic and high normal lactic, which can occur when pyruvate dehydrogenase is not functioning appropriately. We had elevations of citric, which can occur when we have a block in the alpha ketoglutarate dehydrogenase enzyme. And we have a one specific marker, the 3-oxo-3-methylvaleric acid, elevated because of some deficiency in this branched chain ketoacid dehydrogenase. Not typically or not coming from a true genetic disease, but because of deficiencies in various nutrients. Okay, this is just another view of this particular enzyme complex. I'm just really trying to bring the attention that there is a relationship between these different enzyme complexes to those core nutrients. And then the final marker I just wanted to highlight was one that you see from time to time called 4-hydroxybutyric acid. So this is a strange one. There is a genetic disorder called succinic semialdehyde dehydrogenase deficiency. So notice that glutamic acid gets converted to succinic acid to enter the Krebs cycle. And that we need a couple enzymes in order for that to happen, particularly that enzyme called SSADH, which is our succinic semialdehyde dehydrogenase. In this very rare genetic disorder, there is a deficiency of that enzyme. And we can get massively elevated levels of 4-hydroxybutyric, which is also called gamma-hydroxybutyric acid. And then that has toxic influences in the brain and nervous system. What's interesting is one of the issues of elevated 4-hydroxybutyric is it can cause, what's the right word I'm looking for? It can really just blunt cognitive abilities. Too high levels, it can actually cause sedation. So where's this coming from? The 4-hydroxybutyric. It's not at the level that would be consistent with the succinic semialdehyde dehydrogenase deficiency disorder. But just to check, and this is something I'd recommend you have handy. You can bookmark these websites. This is just one of them. This is the National Organization for Rare Disorders. So whenever you see one of these markers like this and you look at the interpretation section and go, is that where's that coming from? What could that be linked to? Is that happening in this child? Well, if you go to this particular page on this website, it shows that as of 2020, there has been 450 patients worldwide that have been identified. What's the chance that you're going to be seeing that in your integrative functional practice? So very unlikely that's happening in this particular case. What is more likely happening is that this particular enzyme, like many dehydrogenase enzymes, are in part supported by the presence of vitamin B3, more specifically nicotinamide adenine dinucleotide. Now, this is a deeper pattern to see on the oat, so I don't expect people to sort of recognize this type of pattern, right off the bat. But this is the power of the organic acid test and why it's so useful in clinical practice to learn how to utilize. So there's a lot to the test, and this particular case was, fairly complicated with regards to just kind of straight up organic acid test interpretation. So in conclusion, when you're learning to evaluate an organic acid test, it's really critical to focus on markers that are commonly seen. So you will commonly see arabinose, and you'll commonly see high oxalic acid. You'll commonly see high succinic acid. You will commonly see elevated Clostridium markers. Those are the things that show up often. The next level is that pattern recognition. And that's really what the new Mosaic OAT format is all about, the report enhancement. It's to draw attention to these different patterns to help move along your ability to clinically interpret the OAT and apply it more quickly and effectively in clinical practice. You always want to apply the clinical presentation to the OAT findings. Do the markers line up with the symptoms and their overall condition? And then again, look at, does it make sense? If you see some rare marker, is it likely the child or the individual has some rare disease? Probably not. It's probably just elevated because of either some interference or it might be a nutrient deficiency. In this particular case, they had ongoing mold exposure in their home. They also had a lot of overgrowth of candida and these Clostridium markers, and they can create their own mischief. Candida, for example, and some of the compounds it produces can lead to a number of different deficiencies. It can lead to B6 deficiency. It can lead to B1 deficiency. Multiple nutrient imbalances. You always want to inquire about diet. Is the child eating a robust diet? Or are they very selective? If they're selective, like many autistic kids are, they're going to be nutrient depleted. If they have poor gut function, they may not be absorbing their nutrients effectively. And the other thing too is a lot of these B vitamins, it's true of B6, it's true of B3, it's true of B2, it's true of B1. When there's a lot of demand, okay, either because of other existing nutrients, chemical exposures, mental emotional stress, physical stress, a combination of all of the above, is there's high metabolic demand on these nutrients. And if it's not being supplemented and supported in the diet, you're going to start to see deficiencies and gets reflected on the organic acid test. So again, you want to focus on what's most likely happening as opposed to some rare condition or set of circumstances with regards to certain symptoms. So like anything in functional integrated medicine, conventional medicine, anything in healthcare, anything really in our life with regards to things that we're learning about, there's always more to learn. So at Integrated Medicine Academy, we have individual courses, mastery courses, and we also have what are called specialty core tracks. Let me focus just real quickly on the individual courses. So we have a number of them: functional, autism, advanced, essential, hormone, etc. Now, with regards to OAT information, the essential and the advanced are the two courses that really get into the meat of the organic acid test. However, in our functional medicine mastery course, our autism mastery, toxicity, Clostridia, candida, even mitochondria, there is discussion about the organic acid test. You're going to be hard pressed to get away from a lecture of mine or a course of mine that doesn't somewhere talk about organic acid testing. We have core tracks. So functional autism, hormone, and mitochondria. So these core tracks are made up of different individual courses. And so if you're interested in learning more about Integrative Medicine Academy, the courses we have, the tracks we have, the membership levels, make sure to go to the homepage. You can look under any one of these particular sections and get more information. And I was going to say, also under the resources is where you can find recordings of past webinars. There's a library of educational videos as well that you can readily access. So there is the website, integrativemedicineacademy.com. If there's any questions, you can email us at admin@integrativemedicineacademy.com. So there's just one question, and then we'll end things here. If Candida becomes opportunistic with elevated arabinose, would it not be best to look deeper to why it's opportunistic, like a stool test, instead of recommending nystatin? And that's absolutely, it's not a bad idea. In fact, one of the things I mentioned up front is you could do stool testing to look for other problems, because we may pick up on a parasitic infection. There may be underlying digestive problems, inflammatory issues that might be happening, other pathogens at play. So I love stool testing. I love comprehensive stool testing. It complements the organic acid test very much. So 100%, that would be a strong consideration to do, as opposed to just, starting on nystatin or some other antifungal. So thank you for that question. Okay, everybody, that's it for the webinar here. Again, the website is Integrative Medicine Academy. admin@integrativemedicineacademy.com is the email. So just go ahead and reach out to us if you have any additional questions. Again, I'm Dr. Kurt Woeller for Integrative Medicine Academy. Thank you.